Hello everyone, myself Dr. Bindurani MK, Professor in the Department of Anatomy, Sri Siddhartha Medical College, Tumkur. So today's topic is about the inguinal canal. So competencies under these headings are to describe and demonstrate extent, boundaries and contents of inguinal canal, including the Hasselbeck's triangle, and also explain anatomical basis of the inguinal hernia. Okay, we have a case scenario here. A 70-year-old patient, known case of chronic constipation, presents with dragging pain in his right groin region. So physical examination revealed a small globular swelling in his right groin above the right pubic tubercle, which expands on coughing. A diagnosis of inguinal hernia was made. So we have questions here. What is inguinal canal? Write its boundaries and contents. What is inguinal hernia? Explain anatomical basis for it. And what are the types of inguinal hernias with differences between them? At the end of the session, one should be able to answer for these questions. Okay, so coming to the inguinal canal, so it's a musculoaponeurotic canal or a oblique intermuscular passage, musculoaponeurotic passage present in the lower part of the anterior abdominal wall just above the medial half of the inguinal ligament. Okay. So what is inguinal ligament? So this is the image of the anterior abdominal wall, and here we are seeing the muscle of external oblique abdominis, and this is the aponeurosis of the same muscle. The lower free border of this muscle is folded backwards on itself, okay, to form the inguinal ligament. So this inguinal ligament is attached laterally to the anterior superior iliac spine and medially to the pubic tubercle. So this inguinal canal measures about 4 centimeter in length. It is directed downwards, forwards and medially. So it extends from deep inguinal ring. Okay, it extends from deep inguinal ring to superficial inguinal ring. So this is the extent from deep inguinal ring to superficial inguinal ring. So what are the boundaries of inguinal canal? So it's a canal. So it will have the inlet, outlet, roof, floor, anterior wall and posterior wall. So let us see each boundary. So first is the inlet. So inlet of the inguinal canal is formed by the deep inguinal ring. It's also the lateral end of the inguinal canal. What is the deep inguinal ring? It's an oval deficit or an oval opening in the fascia transversalis. Okay, so this is the fascia transversalis. It is the deepest layer of the anterior abdominal wall. Okay. So, deep inguinal ring is an oval deficit or a aperture present in the fascia transversalis 1.25 centimeter above the midinguinal point. So, there is a difference between the midinguinal point and midpoint of inguinal ligament. So, midinguinal point is a midpoint between the anterior superior iliac spine and the pubic symphysis, whereas the midpoint of inguinal ligament is a midway between the anterior superior iliac spine and pubic tubercle. So deep inguinal ring, it's an aperture in the fascia transversalis 1.25 centimeter above the mid-inguinal point. So it is comparatively, it is larger in males, and one important relation we have to note here is, so as you can see here, medially this deep inguinal ring is related to inferior epigastric artery. This is very important. So as you can see here, so medially it is related to the inferior epigastric artery. So next is the outlet. Okay, outlet of the inguinal canal is formed by the superficial inguinal ring. So it's also called as the medial end of the inguinal canal. So what is it? So it's a triangular slit present in the aponeurosis of external oblique abdominis muscle. Okay, so superolateral to the pubic crest. Okay, so this is the pubic crest. So superolateral to that, okay, superolateral to that we can see there is a triangular slit in the aponeurosis of external oblique abdominis. So that is the superficial inguinal ring. So it is triangular in shape. So it will have the base which is formed by the pubic crest, apex which is formed by the fusion or the union of the superior crura and inferior crura. So superior crura medially is attached to the pubic symphysis. So inferior crura is attached laterally to the pubic tubercle. So okay, so this is the superficial inguinal ring. Okay, so in this image, so you can appreciate, so this is the external oblique aponeurosis. Okay, so this is the aperture, superficial inguinal ring. Okay, cut part of the superficial inguinal ring from where the content of the inguinal canal, that is the spermatic cord, is emerging out. Okay, and is suspending the testis in the scrotum. Okay, next moving on to the next boundary. So that is the anterior wall of the inguinal canal. Okay, so anterior wall of the inguinal canal. So this is the inguinal canal extending from the deep inguinal ring to the superficial inguinal ring, right? Okay, so anterior wall. So anterior wall in its whole extent, that is from deep inguinal ring to superficial inguinal ring, it is formed by the skin, superficial fascia and the aponeurosis of the external oblique abdominis muscle. Okay, so in its lateral half, this anterior wall is reinforced by one more muscle called as the internal oblique abdominis muscle. So the anterior wall is formed by the mainly two structures in addition to the skin and superficial fascia. So they are the external oblique abdominis aponeurosis in its whole extent, and also in the lateral half also by the internal oblique abdominis muscle. So okay, so this is the anterior boundary of the inguinal canal. So in this image, so this is the diagram you are supposed to draw for the inguinal canal in the theory paper. Okay, so here also we can note the anterior wall structures, right? So anteriorly it is formed by the skin. Okay, yellow one is the superficial fascia, external oblique muscle with the aponeurosis. Okay, then the lateral part is reinforced by the internal oblique muscle. Okay, so this is superficial deep inguinal ring, and this is the superficial inguinal ring, and this is the inguinal canal. So posterior wall is formed by what? Which is the deepest layer of the anterior abdominal wall. So it is the fascia transversalis. Okay, so in its whole extent, that is from deep inguinal ring to superficial inguinal ring, posterior wall is formed by the fascia transversalis, this blue color one. Okay, so it's formed by the fascia transversalis. Of course, in its medial part of the posterior wall is also reinforced by two more structures. That is the medial half is strengthened by the conjoint tendon, and next is it's also supported by the medial 1/4 is also supported by reflected part of inguinal ligament. So what is conjoint tendon? So conjoint tendon is nothing but the aponeurosis of internal oblique abdominis muscle blends with the aponeurosis of the transversus abdominis to form the conjoint tendon. So that is reinforcing the posterior wall. Okay, medial part of the posterior wall is reinforced by the conjoint tendon. Okay, so this is the anterior wall and posterior wall of inguinal canal. Next is the roof of the inguinal canal. Okay, so roof of inguinal canal is formed by, as you can see here. Okay, so it is the internal oblique abdominis muscle, fibers of the internal oblique abdominis and also the transversus abdominis. So they form the roof of the inguinal canal. So which structure forms the floor of the inguinal canal? So as I already mentioned, so this is the external oblique abdominis muscle. So its aponeurosis, lower border of the aponeurosis of external oblique abdominis muscle is folded backwards on itself and is thickened to form the inguinal ligament. So when it is folding backwards, it forms the grooved surface here. So this upper grooved surface of the inguinal ligament is forming the floor of inguinal canal. Okay. So coming to the contents of inguinal canal. Okay, are the structures passing through the inguinal canal. So it is different in males and females. Okay, in the males, the contents are the spermatic cord and ilioinguinal nerve. Whereas in case of the females, the contents are round ligament of uterus and ilioinguinal nerve. So as we can see in this image, so this is the inguinal canal. So this is the spermatic cord. Okay, spermatic cord, and this is the ilioinguinal nerve, and this is the spermatic cord, which are forming the content of inguinal canal. So as we can see in this image, so here we are seeing this is the superficial inguinal ring, okay, from where the spermatic cord is coming out. Okay, so this is spermatic cord and this is the ilioinguinal nerve, which are emerging from the superficial inguinal ring. Okay, then one thing we have to note here, that the spermatic cord and round ligament of uterus. Okay, they are considered as the complete content of the inguinal canal because they enter the inguinal canal through the deep inguinal ring. Okay, they traverse the whole of the inguinal canal and they exit out of the inguinal canal through the superficial inguinal ring. That's why they are considered as the complete content of the inguinal canal. Whereas the ilioinguinal nerve is considered as the partial content. Why? Because it enters the inguinal canal not by passing through the deep inguinal ring. Instead, it enters the inguinal canal by piercing the internal oblique abdominis muscle. Okay, it pierces the internal oblique abdominis muscle and then enters the inguinal canal. Then it runs anterior to the spermatic cord or the round ligament of uterus in case of females, and it comes out of the inguinal canal through the superficial inguinal ring. So that's why it is considered as the partial content. Yes, what are the contents of spermatic cord then? What is spermatic cord? It's a tubular structure, okay, which suspends the testis in the scrotum. Okay, so what are the contents of the spermatic cord? So it has got three coverings also. So from outer to inner. So the outermost covering, okay, it's called as the external, green color one is the external spermatic fascia. So it is the continuation of the external oblique abdominis muscle. Okay, so next is the cremasteric fascia. So cremasteric fascia is the continuation of the internal oblique abdominis muscle, and the innermost is the internal spermatic fascia. So it is the continuation of the fascia transversalis. Okay. So now, what are the structures present within the content of a spermatic cord? So it presents three arteries. So it has got three coverings. It also has got three arteries. So what are the three arteries? First is the testicular artery. Okay, so it's a branch of the abdominal aorta, testicular artery. Then we have the artery to the ductus deferens. So it's a branch of the inferior epigastric artery. We also have cremasteric artery. Okay, so it's a branch of the inferior vesical artery. Okay, so these are the three arteries present in the spermatic cord. So apart from this, so it's also carrying the veins of the testis. So the veins of the testis are called as the pampiniform plexus of veins. Okay, so they are called as the pampiniform plexus of veins. Even they form the content of the spermatic cord. Then we also have got nerves. What are the nerves? Genital branch of genitofemoral nerve, okay, and sympathetic nerves surrounding the vessels. Okay, so these also form the content of spermatic cord, and even the lymphatics coming from the testis, and also one more important thing, remnant. Okay, remnant of the processus vaginalis. Okay, so this is also present in the spermatic cord, remnants. Okay, so we know that inguinal canal is a site of potential weakness. Okay, so it's a potential site of weakness in the anterior abdominal wall. So deep inguinal ring, it's a deficit in the fascia transversalis. So abdominal organs during increased intra-abdominal pressure, for example, during chronic cough or during constipation or weightlifting, okay, so or chronic urinary difficulties, passing difficulties in the urine. So whenever there is increased intra-abdominal pressure, so abdominal contents can pouch out, okay, they can protrude through this deep inguinal ring and they can enter the inguinal canal. So that is called as the inguinal hernia, okay. But this inguinal hernia does not happen, that does not occur. Why? Because so there are certain natural defense mechanisms which prevent the occurrence of the hernia, okay, inguinal hernia. So what are these mechanisms? So they are flap valve mechanism, okay, guards of inguinal ring, shutter mechanism, slit valve mechanism, and ball valve mechanism. We'll see one by one. Okay, so first is flap valve mechanism. So this is because of the oblique nature of the inguinal canal. So this superficial inguinal ring and deep inguinal ring, they are not exactly opposite to each other. Okay, instead, deep inguinal ring is on the deeper plane and superficial inguinal ring will be more on the superficial plane. They are at the different coronal planes. Okay, so whenever there is increase in the intra-abdominal pressure, okay, there will be approximation of this anterior wall and posterior wall. So that itself will prevent the occurrence of the hernia, inguinal hernia. So that is called as the flap valve mechanism. Okay, so it closes the canal like a flap. That's why it's called as a flap valve mechanism. So next is guards of inguinal ring. So these deficit points, they are guarded by additional structures. Okay, for example, superficial inguinal ring, okay, it is guarded by the conjoint tendon and also the reflected part of inguinal ligament. Okay, similarly, deep inguinal ring is guarded anteriorly by the fibers of the internal oblique abdominis muscle. Okay, so next is slit valve mechanism. So I told superficial inguinal ring is a triangular aperture in the aponeurosis of the external oblique abdominis muscle. Okay, it will have two crura. So when this external oblique abdominis muscle contracts, okay, so the two crura, superior crura and inferior crura, they get approximated with each other. Okay, so thereby minimizing the size or the minimizing the space of the superficial inguinal ring. Okay, so like a slit, they are closing this thing like a slit. So that's why it's called as the slit valve mechanism. Okay, then one more is the ball valve mechanism. So here it's also called as the cremastric plug. So contraction of cremaster muscle pulls the testis up and closes the superficial inguinal ring. Okay, so this is called as the ball valve mechanism. And one more is a shutter mechanism. We should note that the internal oblique abdominis muscle, it has got triple relation with the inguinal canal. What are the triple relations? It is forming the anterior wall, it is forming the roof, it is also forming the posterior wall. Okay, it has got triple relation with the inguinal canal. Okay, so when this muscle contracts, so what happens? So the roof and floor are approximated with each other, okay, like a shutter. So that is called as the shutter mechanism of the internal oblique abdominis muscle. Okay, so these are the some of the defense mechanism occurring, okay, so present which prevent the occurrence of the inguinal canal. Okay, so one more thing you should be aware of is the Hasselbalch's triangle. It's also called as the inguinal triangle. Okay, Hasselbalch's triangle or inguinal triangle. Okay, it is named after the anatomist and the German surgeon Franz Caspar Hasselbalch. So where do we see this Hasselbalch's triangle? It is seen on the deeper aspect of the lower part of the anterior abdominal wall. It is seen on the deeper aspect in the dissection. Okay, so what are its boundaries of this Hasselbalch's triangle? So it is so this is the Hasselbalch's triangle. Okay, so medially it is bounded by the lateral border of the rectus abdominis muscle. Laterally it is bounded by the inferior epigastric artery, and base is found by the inguinal medial half of the inguinal ligament. Okay, so these are the boundaries of the Hasselbalch's triangle. As we can see here, so this Hasselbalch's triangle is further divided into two parts by obliterated umbilical artery. The line shown with broken line, no? So that is the obliterated umbilical artery. So that divides the Hasselbalch's triangle into two parts. Okay, so medial part and lateral part. So medial part is strengthened by the conjoint tendon, whereas comparatively lateral part is weak. Okay, so these are the two divisions what I mentioned. So lateral part of the Hasselbalch's triangle and the medial part of the Hasselbalch's triangle. So next is inguinal hernia. So what is inguinal hernia? It is the abnormal, okay, it's the abnormal protrusion of the abdominal contents into the inguinal canal. Okay, so it may be a peritoneum or a loop, small loop of intestine or a mesentery can protrude out, okay, through the into the inguinal canal. It's called as the inguinal hernia. Okay, so there are two types of inguinal hernias. So one is the indirect inguinal hernia and the direct inguinal hernia. So indirect inguinal hernia, so here the abdominal contents enter the inguinal canal through deep inguinal ring. Okay, they are entering the canal through the deep inguinal ring. So it is called as the indirect, okay, indirect inguinal hernia. So what is direct inguinal hernia? So here abdominal contents, they enter the inguinal canal by pushing the posterior wall of the inguinal canal. Okay, through the posterior wall of the inguinal canal, they enter into the canal. They push the posterior wall and enter into the inguinal canal, and not through the deep inguinal ring. Okay, so this is the direct inguinal hernia. Okay, so indirect inguinal hernia is further, it can be classified into two types. Congenital indirect inguinal hernia and acquired indirect inguinal hernia. So congenital indirect inguinal hernia is the common, okay, when compared to the acquired. Okay, so it is due to the presence of persistent processus vaginalis. Okay, processus vaginalis is a communication between the peritoneal sac and the tunica vaginalis, which is the outer covering of the testis. Okay, when that is there, okay, so it acts like a pathway for the abdominal contents to protrude through this. Okay, so that is the persistence of processus vaginalis is seen in the congenital indirect inguinal hernia. Acquired indirect inguinal hernia, it is comparatively rare. Okay, so here it is due to the increased intra-abdominal pressure. Okay, as in the weightlifting or in the chronic cough. Okay, like that. So what are the features of this indirect inguinal hernia? It is common in children and young adults. So entry of hernial sac, it is, as I said, mentioned earlier, so it is through the deep inguinal ring. So deep inguinal ring is related, it is present lateral to the inferior epigastric artery. So the entry of hernial sac lies lateral to the inferior epigastric artery. So this is very important, as we can see in this image. So this is the inferior epigastric artery and this is the deep inguinal ring. So we can see here the loop of intestine. Okay, so it's entering the deep inguinal ring. Okay, traversing the inguinal canal. Right. Okay, so it's coming out of the superficial inguinal ring also, and it has descended up to the scrotum. Okay, so this indirect inguinal hernia is also categorized as the complete and incomplete indirect inguinal hernia. Okay, complete means it descends up to the scrotum. Incomplete means it will be arrested. Okay, it will stop at the inguinal canal. Okay, so this is the inferior. This relation is very important. Okay, so hernial sac is entering lateral. Okay, lateral to the inferior epigastric artery. So next is the direct inguinal hernia. Okay, so here abdominal contents are entering the inguinal canal. Okay, directly by pushing the posterior wall of the inguinal canal. Okay, so what are its features? So its features are, it is more common in elderly individuals. Because why it is common in elderly individuals? Because as age advances, there will be decrease in the tone of the anterior abdominal wall muscles. Okay, so here one more thing we have to note. Entry of hernial sac lies medial to the inferior epigastric artery. It is not through the deep inguinal ring, right? Okay, so this is the inferior epigastric artery and this is deep inguinal ring. Please note that the hernia is protruding, okay, medial to the inferior epigastric artery here, and that is through the Hasselbalch's triangle. Okay, that is through Hasselbalch's triangle. So what are the types of direct inguinal hernia again? Okay, so based on the whether it is protruding through the lateral part of Hasselbalch's triangle or through the medial part of the Hasselbalch's triangle. So direct inguinal hernia is classified into two types: medial direct inguinal hernia and lateral direct inguinal hernia. So what are the coverings? What are the coverings of lateral direct inguinal hernia? So coverings of lateral direct inguinal hernia from inner to outer. It is the parietal peritoneum, fascia transversalis, cremastric fascia, external spermatic fascia and skin. Okay. Whereas in case of medial direct hernia, the coverings are the parietal peritoneum, fascia transversalis, but it is the conjoint tendon. Okay. Instead of cremastric fascia, here we are finding, because it's medial, right? Okay. So that's why it is the medial part of Hasselbalch's triangle is strengthened, isn't it? Okay, by the conjoint tendon. So here the covering is formed by the conjoint tendon, and next is external spermatic fascia and skin. So here, so this is the indirect inguinal hernia. So what are the coverings in indirect inguinal hernia? From inner to outer: parietal peritoneum, internal spermatic fascia, cremastric fascia, external spermatic fascia, skin. Okay, so this in direct inguinal hernia, this internal spermatic fascia will be replaced by fascia transversalis. This is the difference in the coverings of the indirect inguinal hernia and direct inguinal hernia. In indirect inguinal hernia, the covering will be internal spermatic fascia, whereas in direct inguinal hernia, the second covering, so that will be the fascia transversalis. Okay. So coming to the differences between the indirect inguinal hernia and direct inguinal hernia. So incidence. So comparatively, indirect inguinal hernia is more common when compared to the direct inguinal hernia. Age. It is common in children and young age, indirect one. Direct one is common in elderly because direct one, it is due to the weakness of the anterior abdominal wall muscles. It usually occurs in the elderly people. That's why it is common in the elderly. Cause for the indirect inguinal hernia is mostly congenital. That is the persistence of the processus vaginalis, which is the communication between the peritoneal sac and the tunica vaginalis of the testis. Okay, so that is the cause in the case of the indirect inguinal hernia. There, in the direct inguinal hernia, the cause is, as I mentioned, it is the reduced or weakened muscle tone. Next is direction of sac. So in case of indirect, it is oblique, downwards, forwards and medial, whereas in case of direct, it is straight forward. So coverings of hernia. So this is important. Okay, so from inner to outer, so first will be the peritoneum. In case of indirect inguinal hernia, so first will be peritoneum, next will be internal spermatic fascia, cremastic fascia, external spermatic fascia and then skin. Okay, what about here? So here, instead of internal spermatic fascia, so here it will be the fascia transversalis. Okay, and conjoint tendon in the medial direct hernia. Okay, so and in the lateral direct hernia, again it will be cremastic fascia only. Next, external spermatic fascia and skin. These are the coverings of the hernia in the indirect and direct hernias. So here once again, shape of the hernial sac, it is pear shaped in case of the indirect and globular in case of direct, and extent. Usually indirect one will extend almost up to the scrotum, but usually it remains confined to the direct will remains confined to the inguinal canal. So neck of hernial sac is narrow in the case of the indirect inguinal canal. It is comparatively wide in the case of the direct inguinal canal. So what is its implication? If it is narrow, so more common for the intestinal obstruction. Okay, so intestinal obstruction is more common because the hernial sac neck is narrow. Okay, so narrow in the case of the indirect inguinal hernia. So whereas wide intestinal obstruction is less common in the case of the direct inguinal hernia. And reducibility of the hernia. So sometimes it will be irreducible, whereas in the case of direct inguinal hernia, it's always, most of the times it will be reducible. And internal ring occlusion test. Okay, so what happens here in internal ring occlusion test? Okay, so first hernia will be reduced by the surgeon. Surgeon will reduce the hernia. Then they will occlude the deep inguinal ring with the thumb. And patient is asked to cough. Okay, so if it is the indirect inguinal hernia does not appear. Okay, so whereas if it is direct inguinal hernia, then the hernia will appears. Okay, so that is, here it is considered as the internal ring occlusion test is considered as positive. Here it is considered as negative. Okay, so this is about the inguinal canal. Okay, to summarize, okay, so it's a musculo-aponeurotic intermuscular passage. Okay, so present just above the medial half of inguinal ligament. So it is, one should be aware of the boundaries, different boundaries of the inguinal canal, and also it is important as it is more prone for the inguinal hernia. Inguinal hernias, as they form the 75% of the external hernias are due to the inguinal hernias. Thank you.